Good afternoon, everyone, and welcome to this Australian Centre for Value-Based Healthcare webinar, Driving Value and Innovation, Learning Health Systems in Practice, which is presented in partnership with EBM Analytics. I'm Emma Hoban, the Manager for the Australian Centre for Value-Based Healthcare, and it's my pleasure to be with you today. Today, I'm joining you from the land of the Ngunnawal people and pay my respects to their elders, past, present, and emerging. I would like to acknowledge and pay my respect to the traditional owners on the many different lands on which we meet and recognise their continuing connection to land, water and culture. To support the implementation of person-centred value-based health systems in Australia, systems of continuous learning and improvement are needed that drive innovation and enable the delivery of the right care to the right people in the right place at the right time. Learning health systems have been identified globally as the next stage in quality improvement, providing a systematic approach to iterative, data-driven improvement, where a learning community is formed around a common ambition of improving services and outcomes. Today, we're going to hear from a panel of experts on the topic of learning health systems and how they are being used in practice to drive innovation and improvement. If you have any questions for our panelists throughout the session, please use the Q&A function at the bottom of your screen, and we will try to get to them throughout the discussion. Hosting this discussion today will be Dr. Corey Scholz, the Chief Science Officer and co-founder of EBM Analytics. Dr. Corey is an experienced leader in the healthcare research and innovation sector, spearheading transformative initiatives globally to provide expertise in clinician-led health research and implement systematic change in the alignment with learning health systems. So over to you, Corey.
Thanks so much, Emma, and thanks to everyone that's attending and to the panel here. What I'd like to do is kick off with a very brief presentation on what we're talking about in our title in terms of learning health systems, a little bit of our experiences with those concepts, and then I'm going to hand over to our other esteemed panel members for a couple of other presentations on a little bit more of the practical side of some of these concepts, and then we'll bring it back together and have a bit of a panel discussion and hopefully some of your questions around how we move into this domain together, really. So let me just get this up and running. Oops. So I'm sure you'll let me know if you can't see that, but we'll work through a couple of these key concepts and hopefully draw out some more discussion through the session. So Emma's well and truly introduced me, so I can move through that. What I'll do is talk about what we mean by a learning health system and how we've approached this. So there's a couple of formal definitions out there to work off. But really the key elements here is a iterative process, a cyclical process between practice, data and evidence. And really it is about pulling together both internal experiences, objective data, and systematically integrating them with external evidence. And the main thing is that it's underpinned, that entire process is underpinned by both quality in the research approach, the auditing approach, and the evidence that's used to make decisions within those systems. So the key question that we often face is why do we need to change? And there are a range of different drivers that we've perceived will be driving changes in a whole host of different organisations. So really starting from the left here, both at the population and society level, we've got key demographic changes occurring at an increasingly rapid rate. We've also got different expectations through society around how they interact with their healthcare and how well that healthcare is delivered and delivered for them at the individual level as well. But importantly, as we move around this particular diagram, we've got key health effects. Most recently, the COVID-19 pandemic, which will be with us, and the effects of that will be with us for many years to come. Clearly changes in priorities and disease burden, both geographically, so not two areas have exactly the same priorities in terms of the healthcare that they're delivering, but also in terms of climate change, which is becoming increasingly relevant in the healthcare space. And maybe we'll explore that a little bit later on in the presentation as well in the discussion. There's obvious economic drivers for changing the way that we deliver healthcare. Both funding and reimbursement models continue to evolve very rapidly. Staffing, again, these things are not unrelated to each other. So the pandemic has drawn out some very key and pressing issues in terms of staffing key organisations, attracting, retaining, developing that workforce. And then ultimately, and where our experience has been quite prominent, is really the bedside to bench and back again. So the clinical frustration that often occurs in practice and wanting to deliver better care and target better ways of delivering that care, both from a clinical perspective, but also from an administrative perspective, and getting those elements of organisations working together. And that's often drawn from observations in practice. And so what is the missing piece here? So it isn't every organisation learning, and that's absolutely true. Every organisation is working in the most part well, but identifying what can be done better needs to be done systematically and in organised ways. So what we often find is that healthcare organisations are really good at measuring activities, what they're doing, their internal processes, how much they're spending, but the organisational impact at the individual level. So what they're doing for the patient, as well as the community that they operate in, is often lacking or is still in development. And so that's really what we wanted to target in this process. So learning better ways of how to make that impact at the patient level and working out what works and what could be improved. And so when we centre the evidence towards the patient, we need that evidence to be timely. So it needs to be a relatively short turnaround time. It needs to be relevant to the patients, and it needs to be relevant to the local setting. And so learning health systems that put the patients first, they are able to identify where it's letting down stakeholders, particularly the patient. It canvasses that global knowledge to make those improvements, and it validates it against local conditions. And so when we're talking about drawing evidence and bringing it into a healthcare setting, often that evidence is not tuned and is not valid for the local either geography or the local population. And so bringing that process into the organisation helps to generate better evidence and evidence that people trust to make decisions in terms of how things are done. So defining that success at the patient level, treating them as a person, looking at learnings that are not necessarily entirely positive and targeting those, how management and prioritization is achieved, and then really, in our experience, working from the bottom up. So working from those individual observations all the way up to those system changes. And so when we talk about relevant to the patients, what are some of those outcomes? And if we look at the WHO World Health Organization classification of function and disease, we see these sort of common areas in terms of looking at body structures, how are tissues and structures being restored, looking at body function, so how well do those organs and systems work, the activities and the participation of that patient back in society, both with activities that they prefer to do recreationally, but also getting back to work, engaging with friends and family, as well as environmental factors. So how much they rely on societal or system support to function day to day. And so this is a real challenge to try and do all of these things. So every organisation has different needs, they have different priorities, but being able to achieve that in a environment with often limited resources can be a real challenge. So drawing external evidence from a variety of those different sources, clinical practice guidelines, specialty recommendations, other guidelines and policies, and then merging those with trying to innovate in ways of ideas, new technologies, potentially synthesizing different evidence and modifying some of these documentations becomes a challenge across all of these levels of organisations to then translate that to the bedside. And so learning within a healthcare environment, healthcare setting, is not just about collecting data and organising data. It really is about translating both the knowledge and generating new evidence across a question and problem framework. So really understanding what we're asking, the problem that we're trying to solve, and using all of those different resources that are available to bring about better ways of operating. And so optimizing patient outcomes really is about achieving the best outcomes for the individual, and it's an ongoing collaborative effort, but it's person first and supported by technology, not the other way around. What it isn't, and what's important to keep in mind, is that it's not about rationing treatments or rationing resources based on risk. It's not the next new algorithm or platform, particularly in terms of machine learning, artificial intelligence. They're important tools in this process, but they are not the destination. And so the thinking critical learning system is really about putting those things in a coherent framework and feeding off each other in terms of practice, in terms of the data that's collected that represents that practice, and turning it into evidence to then iterate practice changes. And one of those tools that can help underpin that process, that hopefully we'll hear about a little bit more this afternoon, is a clinical quality registry that starts to pull together some of those elements and allows key stakeholders to access that information for different purposes. And so really the next steps are around starting with a vision for different organisations and different departments within organisations, depending on their size, considering resourcing, considering capacity, and then implementing or supplementing new and existing systems. And so working on what exists and building on that, achieving good governance in terms of new systems, new data collection, making sure that it is embedded with quality from first principles, and then ultimately it's conversational and responsive to the needs of both leaders in the organisation and the organisation as a whole. And so with that in mind, I'll hand over to Gillian and look forward to working through some of your questions that I'm hopeful that I've instigated in that short presentation. So hopefully, Gillian, you're ready and waiting, got the finger poised, and I'll hand over to you.
Let me just, you can all see my screen there?
Yes, we've got it.
Wonderful, wonderful. So firstly, thank you for the opportunity to join you today and talk about the Getting It Right First Time program in Queensland. This program was actually developed in the UK by Professor Tim Briggs, an orthopaedic surgeon, back in 2014, 2015, and it's actually active in over 40 specialties in the UK now. We're not quite there in Queensland, but we're slowly building. And it actually really nicely aligns with a learning health system. So the program itself is really focused on the delivery of high quality care in a sustainable system. It has a real collaborative focus, and when needed, an opportunity to reform. So the components of the program are, it's a clinically led, data-driven program. It provides a level of visibility and transparency over both data and outcome, clinical and health service outcome. And it's got a real quality improvement lens, and we focus on the entire patient journey. So before I go too much further, I just wanted to acknowledge the team that developed this program here in Queensland and implemented it is enormous. We work with a range of stakeholders, both internal and external, but I'd also like to really call out an acknowledgement to Associate Professor Catherine McDougall, who's the current Chief Medical Officer for Queensland, who was our founding clinical lead with Dr. Laurie Malasano, and Jodie Paxton, who was our director, who really enabled the program to gain momentum. So when we look at the program itself, it's a cyclic program. We commence with an engagement schedule where the nominated clinical leads or the recruited clinical leads go out and engage with their peers, and they really go out to understand what's the local context of the site, what are their local challenges, give an overview of the program, and look at what opportunities they might like to focus on. While that's happening in the background, we're developing a data pack. So the data pack is a range of indicators from multiple sources, both internal to Queensland Health and external, and we do use clinical quality registry data through the Joint Registry and the Hip Fracture Registry. And that range of indicators goes across the patient journey. So for example, in orthopedics, we focus on demographics so we can understand our population of interest and any socioeconomic type factors that might influence outcome. We look at waitlist data for outpatient service provision and elective surgery provision. We look at a range of clinical and quality type outcomes. We look at patient-reported outcomes. We look at patient-reported experience. We cover off multiple different efficiency measures. We look at cost and we look at workforce, among many, many other things. Once we've got this data pack, we go out to the site visits and we meet with clinical teams led by a local site champion. And we encourage broad multidisciplinary engagement, but we do leave it up to the teams to bring along who they think it's important to have in the room. And the clinical lead, so for orthopedics, Associate Professor Kath McDougall and Dr. Laurie Malasano would lead a discussion going slide by slide through the range of indicators that we have. And the aim of that is to understand where that particular site sits in terms of their peers, but also in terms of perhaps an evidence base, an expected standard, an average across the state. What's working really well and what are they doing well, where are their great outcomes, what can we learn from them and share with others, but then also where are their challenges or opportunities, what's their frustration, what's the barrier to them driving improvements locally where needed. The second part of the site visit, we invite the executive team along, and we invite everybody from a unit director all the way through to the chief executive. And actually, I think our chief executive attendance rate was about 80% across the site visits. That's a much smaller session where the clinical leads deliver a very brief summary of the data pack, just focusing on some key points. They really drive home what's working well in that site to support the great work that the clinical units and the clinical teams are doing with their communities and their patients. But they also really highlight and elevate what are the barriers and what are the opportunities that the frontline clinicians and clinical teams need their executive to support improvement in. And that might be resourcing, it might be agreement on a process, it might be facilitating relationships with partners or local discussions to drive change. And then following that, we provide a bit of a report and summary on suggested actions that they can pursue. All the while as we go, we're looking at it from a system lens, thinking, okay, from a Department of Health perspective, we're seeing consistent opportunities across sites. What can we do to influence improvement and better outcome at a system level? And then we aim to do regular reviews with a more formal review each year. So in practice, really what that means is we use information to drive peer-to-peer review and discussion to look at what's good, what could be better, how do we compare to our peers, develop an action plan, bring the clinicians and managers together to collaborate. We want to harness the knowledge we're getting from our exemplars. If we make a cost saving or an efficiency, we want to really promote a reinvestment to drive further improvement, and we want to keep reviewing and refining as we go. So ultimately, what we ask the sites to do is know your data, know how you compare, and use the data to leverage change, particularly by engaging with your executive teams. The data itself is historically presented in a box and whisker plot. I won't go through it too much, but obviously red and green, good and bad. So if there's a quality outcome, a complication rate, a readmission rate, you'd want to be in the green. If it's just purely a comparison of data across sites that are, from a context perspective, you know, a big site and a little site, you can't really compare an activity number. They're presented in a grey and blue scale. We identify each facility only to that facility, and all other facilities are de-identified, but you can see where they sit in terms of a range or a number. And if you're outside the interquartile range, you're considered an outlier, whether it be a positive or a negative. So in orthopedics, we actually, over the first 2 years of the program, went out to 38 hospitals across the state. We visited every public orthopedic department that had a volume of more than 200 elective procedures a year. And we engaged face-to-face with over 300 clinicians and executives. And the result of that program was that we identified system opportunities, health service opportunities, clinical opportunities, and opportunities to improve patient outcomes. Feedback was really, really positive. The program was embraced. 91% of participants thought it was a good thing. Not surprisingly, 75% of participants said we presented some information they didn't readily have access to, and certainly not in a way that they can compare. 50% of participants identified things that they weren't aware of in the information that we presented that were potential opportunities. Half the sites now have regular relationship meetings with their executive to discuss this sort of information, and almost all sites have progressed improvement opportunities, which is amazing. I'm just going to quickly run through a couple of improvements that we saw at the program level. So knee arthroscopy in patients over age 55 for osteoarthritis is low value care. I don't think anybody disputes that. However, there are a group of patients where arthroscopy over 55 is very reasonable and quality care. It's very hard to differentiate in the data, but there was a risk that clinicians were being asked to explain why they were doing these surgeries. So actually what we did was change the narrative to, in some people, this is a very valuable procedure, but we know the volume should be lower, so let's just monitor it. And we actually saw a reduction over time in the number of these surgeries that were being performed. And the local units were able to clearly articulate that those that were receiving these surgeries were actually receiving value care for their needs because they were looking into it regularly. We saw an overall reduction across hip and knee replacement length of stay, and obviously any efficiency gained through a reducing length of stay is likely to result in a corresponding reduction in cost, but it also creates capacity to deliver more care, better meeting the needs of the community. We saw a reduction in average length of time to hip fracture surgery for our arguably most vulnerable patients, and we also saw a reduction in the number of outliers waiting for surgery longer than clinically recommended. Overall, we saw an increase in the number of trauma sessions allocated to orthopedic surgery as a planned trauma session. So we know that almost half our activity is emergent, but historically and up until 3 years ago, very few facilities had resources allocated for this activity. So the access was inequitable and time to surgery was quite significantly delayed, and we've seen a huge reduction in time to surgery and much better access to planned care for these people. At a system level, there was an identified opportunity around managing modifiable risk factor for some surgical procedures, predominantly hip and knee arthroplasty. So we know that people with a high BMI, poorly controlled diabetes, active smokers are at a greater risk of infection, but each hospital was struggling to get buy-in around supporting pre-surgical optimization. We also know that if we nurse and care for these patients in a ring-fenced environment where we don't have the risk of other patients with infections coming in contact, we have a reduced infection rate, but again, we had trouble getting buy-in. So at a system level, when we could present infection data to the health system executive and to hospital executive and show the evidence that actually if we did things a little bit differently, we could reduce the impact from infection, we were able to develop and have endorsed an infection prevention guideline. And actually, I'm not aware of many departments now that don't have pre-surgical optimization as a formal strategy, and 50% of our sites have an in-principle agreement to manage these patients in a ring-fenced environment. Probably our most proudest achievement from the orthopaedic program was the solution to a very commonly identified problem in a geographical location like Queensland, where we have huge distances between our centres. We had really siloed orthopaedic surgeons and directors. We had departments who didn't talk to each other. We had new directors who had limited leadership support, and basically everyone was facing the same challenges. So through the GIRFT program, we've built a collaborative network for orthopaedic directors called QDOG, the Queensland Directors of Orthopaedics Group. We're very lucky to have our current chair, Dr. Michael Thomas from the Gold Coast. And actually, these guys now meet formally face-to-face once a year. They have 3 informal meetings online around that, and they actively communicate in between meetings, and they're driving the priorities and strategic direction for orthopaedics across the state, which is amazing. Since orthopaedics, we've gone out into emergency surgery, which is a little bit more challenging. In Queensland, we haven't measured this particularly well. In fact, our definitions across our multiple data systems don't actually align. So for the first time, we were able to collectively and collaboratively actually understand what our emergency surgery demand and outcomes is. And not surprisingly, it's almost half our surgical activity, and our patients are enormously acute. Having access to the information and being able to talk to clinicians and executives about this, we identify huge variation in all areas of the service. So patients being admitted from emergency, some were hugely delayed. Access to treatment in time, particularly emergency surgery, there was huge variation, and our most acute patients were often not getting to surgery within clinically recommended time, and very few patients had planned emergency theatre sessions that they had access to, and they were often competing with each other for space. How we maintain our data systems, how we enter our data, how we define our data was varied across most sites. How we identify the priority of patients and categorize them, there was variation, and if a patient was waiting too long, we didn't have a consistent way of identifying how long they were waiting. Had they been cancelled and rebooked? Do they just get delayed? There was no way of actually comparing across sites how we were performing in that space. Clinical outcomes are reported primarily from admitted patient coded data, and we know that that's quite restrictive, primarily due to poor documentation. But in the absence of other systems, we were stuck with it. We do know clinicians have a really strong desire to participate in programs that look at transparent and quality data. So programs like the National Surgical Quality Improvement Program, the ANZ Hip Fracture Registry, are providing really rich, robust, clinically relevant information that we need access to. And we know that when we can measure it reliably, there is significant variation in both performance and outcome. Cost we can't measure is very problematic. There's no differentiation in the data to identify what's a planned or elective case and what's an emergency case in DRG data. So if we're looking at length of stay or cost from a DRG perspective, we can't actually differentiate. And when we look at it as a whole, as you can see, we had a 250% variation for length of stay and a 500% variation for some DRGs in regard to cost. So while the program is really focused on clinical outcomes, the emergency surgery program, I think, highlighted the benefit of looking at system change. And for us across Queensland, we've got 4 key priorities that we're going to progress because of the program. And the first focus priority area is looking at improving access to timely care for emergency surgery patients by really increasing the profile of emergency surgery. We see elective surgery waiting lists and outpatient waiting lists reported in the media constantly, but very rarely do we hear about emergency surgery, and we're trying to raise that profile. We want to try and improve the reliability of data and visibility of quality and safety outcomes, and that's both internally through our own systems, but also engaging in other systems or clinical quality registries to make sure that what we're accessing is meaningful and clinically relevant, and we can use that information to drive good patient care and good patient outcomes. We want to improve the coordination and management of emergency surgery and the systems and processes that we're working within, so that we are efficient, we're productive, and we're providing timely access to care to get really good patient outcomes, and make sure we can continue to collaborate across the state, make sure we're consistent in our practices, we're equitable, and we're really contemporaneous in our processes. That's it for GIRFT. Next step for us will be diabetes, which is coming in the next couple of months, and probably a couple of other specialties to follow. So I'm happy to take any questions at the end if that's okay. I will.
Thanks so much, Gillian. So hopefully Lorenzo's ready there with his trigger finger poised. So I'll hand over to Lorenzo to walk us through at a little bit of a local level. Thanks, Lorenzo.
Thanks, Corey, and thanks, Gillian. I'll just get this slideshow started. Yeah, thanks very much, and really interesting to see, Gillian, that you're starting to look at emergency surgery. I look forward to that. I'm a practicing orthopaedic surgeon at QE2 Hospital, and I'm here today really to talk about our clinical outcome registry. And I guess with respect to the learning health systems topic, I'm hoping to illustrate the value and the potential that a sort of hospital level clinician-led clinical registry and clinical research can have in this area. We're a medium-sized urban hospital, but actually when it comes to elective orthopaedic surgery, we do the majority of the elective orthopaedic surgery on the south side of Brisbane. And in the scale of at least Queensland, there's only 1 or 2 hospitals who do more cases in a year than we do. So we recognise that with this volume, we've got the potential to ask some good clinical questions and answer some clinical questions and improve care at our centre. So round about 5 years ago, the Sharks clinical, sort of orthopaedic clinical outcome registry was set up. It's a collaboration. So locally it's led by surgeons, and we have physiotherapists involvement at the hospital as well. And we collaborate with EBM Analytics, who are an external research organisation. So the data is collected at our hospitals at the sort of surgeon-patient or physio-patient interface in clinics. That data is managed with EBMA, and we have the opportunity in collecting, I guess what we're mostly collecting is patient-reported outcome measures, both pre and post-operatively related to our elective patients. That's hip and knee replacement, shoulder surgery, ACL reconstructions. And we've got the opportunity to use that data to answer questions locally, but also then we can bolt on research projects or research questions with that existing infrastructure to really look at, you know, some of the things that can improve, I guess, the patient journey at our hospital. And we've collected data for about 2,000 patients over the last 4 or 5 years. You know, I've talked a little bit about the goals of that. We wanted to answer questions, but also as surgeons, we have the opportunity really to introduce new techniques, new technology at our own discretion. And we wanted to provide a sort of an ethical and scientific way of doing that. And if I put on my teaching hat, then we wanted to create a culture of data-driven practice and research for our training orthopaedic surgeons as well. And I guess the difference between what we're doing with a kind of bottom-up approach as opposed to GIRFT that Gillian's talking about, or some of the national registries, is that we can collect sort of single centre patient detail at a granular level and answer local questions that perhaps can't be done through coding data or even robust data in national registries or state registries. So just a couple of brief examples of projects, very recent ones that have been done the last 12 months in association with our outcome registry at QE2 Hospital. Gillian touched on length of stay there, and I've actually put in some of the box plots for our hospital that we got from the Getting It Right First Time report. And you can see, looking at the length of stay of our hip and knee replacement patients with a black triangle. So hips, we were about average. but we didn't think we're average. We thought we're better than average, and we wanted to do better than that. And knees were, if anything, in the red there, a little worse than average in terms of the length of stay. So one of the projects led by one of our physios, Gary Kerwin, was we thought, what if we can preemptively target resources in terms of education and allied health input to the likely long stay joint replacement patients before they arrive in hospital. First step in this was to identify who they were going to be. As some of you might be aware, there are a whole number of tools and predictive models out there that you can use to try and guess who's going to have a long stay, and hospitals use these often. We searched the literature to find one that was relevant to joint replacement patients, that was relevant to our centre, and the best model that we could find had been published in Canada in, I think, 2015. Similar kind of setting, similar parameters to what we could collect. And we thought we'll apply this to 200 or 300 of our previous joint replacement patients retrospectively and see whether it would have predicted who stayed longer amongst our patients. And the bottom line is that actually, even though it was the best one we could find in the literature, the tool that we had wasn't much better than a coin toss in predicting who was going to be a long stayer at QE2 Jubilee Hospital. So then I guess we thought, well, what does predict the long length of stay at our hospital? And we followed that up with a project where we retrospectively looked at a whole lot of these parameters in our patients. And when we controlled for a lot of the things you would expect to cause a long stay, what we actually found was the most powerful predictor was the day of the week they were operated on. So you might say to yourself, I don't know about that surgeon who operates on Thursday, and I do some cases on Thursday. So perhaps I'm biased in suggesting that the reason that the patients who are operated on Thursday go home a little later is because almost nobody goes home on Sunday. And that's probably more related to things like pharmacy dispensing, whether there's a flow manager pushing for beds, and resourcing on the Sunday. So I guess this is just an example of local data informing quality improvement. Another brief example, if you can all picture where you think you would be 24 hours after a knee replacement, a lot of people will picture themselves lying in a hospital bed, wearing a hospital gown, lines attached, family sitting about, nurse attending. Whereas what we're actually working towards in a lot of early discharge programs after joint replacement is the patient on the other side of the screen there who's wearing his own pants and doing physio in the gym. And like I said, length of stay is a big topic worldwide, aimed at driving efficiencies and sustainability and improved costs in joint replacement. But we don't, the patient's bladder doesn't always come along for the ride. So funnily enough, one of the limiters to short stay joint replacement is actually urinary retention. And one of the decisions we have to make as surgeons on the day of surgery, patient on the table, is should we put a tube in the bladder before the surgery in order to prevent problems, in order to prevent urinary retention? And there's a vast difference in practice between what people do here. Everybody's got a different idea as to what the right thing is to do. And there's not a lot of good guidance out there in the literature as to what we should do for best practice. We found at our hospital that half of the surgeons used urinary catheters in all of the patients. Half of the surgeons hardly ever used a urinary catheter. The anaesthetist had an opinion. Our nursing staff always want what's best for the patients, but what they really don't like is having to place a urinary catheter at 10 p.m. in a patient with a sore hip on the ward who's in retention. The urologist saw a steady stream of complications, which the other surgeons didn't, and no one was quite sure what the patient thought. So we ran a study where we prospectively looked at almost 300 patients. We asked them to give their patient-reported experiences, their patient-reported urinary symptoms, both before and after the surgery, and we found that 40% of our patients were operated on by a surgeon who liked putting in the catheter beforehand. The other 60%, very few of them actually needed to have the invasive catheter. And when we interviewed them all before and afterwards, we found that that nobody really had a superior experience to anybody else. So the conclusion from this was that probably a lot of the invasive catheterisation of the bladder at our hospital was unnecessary. Look, we've got a lot of other research projects we've been working on, which I won't go into detail on, but I did want to touch briefly on some of the challenges that we've faced in instituting and running this this clinical registry. The first, and it'll be no surprise that resources are a challenge. I guess the lesson has been that research and clinical registries require a variety of expertise. So we have surgeons and junior doctors recruiting the patients in the clinics, consenting them to be involved, collecting the data and doing the surgery, so to speak. But we also need people who have IT expertise with data management and storage. We need someone to navigate the research ethics committees, the Public Health Act, research governance organisations. We need people with tertiary qualifications in statistics. And at the end of the day, someone's got to put together these papers and present these things to get word out there. And at the scale that we're working at, which is relatively small, it's absolutely impossible to have in-house expertise in all of those areas. So the message there from us is that we've found a significant benefit, I guess, in engaging an external research organisation who have this expertise in a scalable sort of, I guess, format for us to use. The other challenge I'm just going to touch on very briefly, perhaps as a discussion starter, is, I guess, the potential issues there are going forward in information security and the implications that has for research viability. So there's an understandable fear and reticence out there around information security breaches, and we've all seen a lot of them recently in the media. But at the same time, there are tools that are available which have the potential to make clinical data collection and clinical research very efficient and very streamlined. And there's a real mismatch between those two areas. Most of these tools are out on the web or in the community. It's not feasible to recreate them at scale in-house in a public health system. And our experience over the last 18 months trying to take our paper-based registry and make it digital has been that there's a lot of pushback, and a lot of it is driven by risk aversion at a political and executive level and management level. And to do that, we've had to liaise with a number of different areas within the public health service. And I think it'd probably be reasonable to say that the people we're working with in these areas, almost or very few of them have as their top priority the facilitation of research. And so that has been a barrier to us, I guess, developing our registry and developing our local research. So I'll just finish off by sort of saying that I think this hospital level clinical registries and research that we're involved with is great because it engages clinicians who are well placed to drive change. It can answer detailed questions that the big data can't, but it is at risk of being sidelined by competing interests. And I think there is a requirement for executive will and it to be part of sort of strategy, future strategies for it to prosper. Thanks.
Thanks so much, Lorenzo. I'll ask you to stay on the video, and we'll get the panel discussion up and running. And if Gillian can come back from the ether, and maybe we can introduce Kylie at this point, the CEO of AHHA, to join in on the panel discussion. I know we've got a few questions lined up, but before we do that, I might open up to Kylie and bring her into the conversation and see if there was any points she wanted to tap into from the presentations and quickly discuss, or you want us to roll into the questions?
Corey, I will just throw to the questions because I know that there are a lot coming through. It was just interesting to hear Lorenzo even refer to it, and I'd be keen to hear from Gillian too. yesterday someone mentioned to me that innovation and this kind of embracing of evidence happens at the speed of trust. And it is trust at that cybersecurity level, but also trust at, between clinicians. When you're sharing data, you're actually quite vulnerable in terms of, what people do with that data. Do you have, in the your experiences of this, how important has trust been?
You want to take that one, Lorenzo?
Sure. Yeah. Yeah. Look, I think for me as a doctor, the person whose trust I'm trying to win the most is the patient, and I think that's where it should come back to. We have, I guess, it's the benefit of sitting across from the patient and explaining that the data we're going to collect, will be held on a certain server here or there. It may, that server may not be based in Australia. We have ethics approval for that. We're collecting the data because we want to improve quality. And when we have that discussion with the patient, it's actually not difficult to win their trust at all. The trust issues we have are more around persuading cybersecurity or management levels that the risks of what we're doing, because there are inherently risks in collecting that data in terms of information security, are worth the benefits. And I guess that's something that's more difficult to sell when we're going up the chain than it is to the patients.
I think from my perspective, we had a huge trust issue when we first started. There was skepticism and there was fear that we would be using clinical outcome data in a punitive way, and we would use information to be able to tell people what they can and can't do and restrict practices and activities. And that obviously for us was never the case. And what we've found over the period of time that we've been running the program is, after the first round, people embrace the program, they trust the program, they trust the information. But actually the sites where we've been able to build the trust and the relationship between the clinical units and the executive are those that are making the sustainable improvements, and they're the ones who are seeing the real success. And it's about not only trusting the information and using it to leverage change, but actually building the trust in the people that can enable you to make the changes. And having that clear dialogue has been really, really important for us.
Thanks. And sorry, Corey, if you'll let me. I saw a couple of questions come through around the patient journey. And I mean, the last few weeks, we've seen the announcement of the interoperability plan, which we'll see healthcare identifiers and people be able to follow through the system. I guess so that does open up even further, issues of trust with data and people's confidence and cybersecurity issues. But how do you see great opportunity with the capacity to be able to share data between other parts of the health sector?
Yeah, I mean, I think we sort of oscillate between feeling very ambitious with what we're doing, and then on the next the next sort of sunset, we feel like we've only just started and we're not even scratching the surface. So I mean, just to take up the previous point in terms of the trust levels, it's not necessarily the patients themselves that are providing the biggest barriers for this process, and in fact they want us to push harder in some cases than even what we're comfortable doing. It really is around what Gillian was saying around how that data is going to be used in the clinical facing side of things. So there's always a dark side with any kind of system or process, and it is building up those relationships between those that are supporting efforts like Lorenzo's at QE2, and how GIRFT is coming in and interacting with different groups. Sorry, that's a bit of a thunderclap in the background on my side. So building up those relationships has been just as important. So yes, there is great opportunity, but there is also a long way to go for us to get to the point where we can really get the environment and get the infrastructure ready for taking up those opportunities and generating that benefit.
Yeah, thanks.
Right, so we'll get into a few questions, I think. So there's been some really curly ones, I have to admit. So let's see if we can start relatively benign and move our way up. So this might be one for you, Gillian, to begin with. So some evidence, or impressive evidence, around the benefits of better triaging, leading to fewer invasive surgeries if a need. So is there any advice that you might have on the role of other interventions or other allied health, I guess, to address some of this patient need and drive these outcomes?
Yeah, sure. Thank you. I think absolutely there's a need to consider how we can use what's available to us across a multidisciplinary team to better meet the needs. There's an enormous amount of evidence and more evidence emerging around appropriate pathways for patients. I think as Dr. Calabro referred, in the surgical space, it's very hard to do a trial around surgery versus no surgery in a blinded situation. So we're very much reliant on theory and principle. But I think as these data systems and the sophistication in using information and reporting patient-reported outcomes and patient-reported experience, as we move more and more into that space, and we're linking these systems so we can actually understand clinical outcome, patient-reported outcome, and surgeon experience across a patient journey, we can drive future enhancement and actually show the outcome for some of these models. I think that's been our barrier, is that providing the evidence to show that alternate pathways or optimization pathways prior to surgery are effective and efficient and result in good patient outcome and experience. So I think we're moving there. I think there's appetite for it. The challenge for us, I guess, has been access to the information across a patient journey to support it, which is where, things, frameworks like Learning Health system is, going to drive those changes.
Great, thanks, Gillian. So this might be one for you to weigh into, Kylie. So it's something that you might have seen a little bit more broadly. So asking about the measuring what the organisation is doing for its workers, with and for its workers, and how those individuals and their actions, behaviours impact organisational outcomes. Is that something you've seen in your travels with healthcare organisations and their workforces?
Yeah, what we hear all the time is, people work in health to improve outcomes. They don't turn up to work not to. And so for systems like this to actually engage people, to actually have, measures of what it is that they're doing and what is working and what's not. I mean, it ties into people's core reason for joining the health workforce. So that can only be a good thing. As Gillian mentioned, it's when people use data for punitive reasons, so that's where there's a real problem. Using it to engage them in improving patient outcomes is what people are turning up for work for.
Yeah, I mean, I can sort of weigh in our experience as well. I guess the direct answer is we haven't been measuring directly from the workers in these different organisations, but we certainly qualitatively notice, and certainly working with Lorenzo and in the department, we see a big uptick in engagement, not in everyone, but in certainly a subset of the clinical team. When they're engaging in this data and they've got their own projects at times, we really see some deeper engagement in the process and how they're thinking about how they're interacting with patients. But it's very small scale at the moment. We certainly haven't seen anything at an organisation level. But yeah, thanks very much for that question. I don't know if the others have got anything they want to add in that space.
I won a Victor Crown.
So the next question is, can each of the presenters please comment about their how they might determine their PROMs? What do they use and how do they determine these? And are they principally quality of life measures? Lorenzo, did you want to kick us off in?
Sure, yeah. I mean, I could put that down in writing as well, but briefly, we use a general quality of life measure, and we use joint-specific patient-reported outcome scores, which are internationally validated for all of our different cohorts within the clinical registry. And then we also collect some other demographic data as well. And for extra studies like the urinary study, we used an internationally validated score that asked the patients what their experience had been and what their satisfaction was.
Yeah, Gillian, has SCERFT sort of dabbled in that?
So we don't collect the data. We use what data is available to us. So obviously the outcome data that we use is pre-existing and pre-collected by other parties, registries, facilities. We do, however, assess the data that we want to use to make sure it is reliable. We make sure that there's a quality focus, and we make sure that it's where relevant condition specific, and that it's comparable and repeatable. So we don't want to present an indicator for patient reported outcome measures, for example, for hip replacement, a Harris hip score, that's only ever going to be collected once, and we're not going to be able to repeat that measure across time. So for us, it's got to be validated, it's got to be available, and it's got to be repeatable.
Yeah, no, I'd certainly back that up. I mean, from our experience perspective, whether it's local or at a greater scale, it really comes down to that trade-off between how much attention do you have from the patient at each time point, which is often not much, and what are the key drivers of success within the measurement process. So if it is a return to function, but in terms of, for example, arthroplasty, it's predominantly a pain relief. So it's relieving pain in the patient. So we would focus on that as a primary outcome, and then layer in as much as we can to achieve other outcomes. So, for example, economic analyses tend to rely on other metrics like quality adjusted life years. So they require a different type of scale. Where we can, we'll build those in. My general approach is one about the patient, one about their limb, and then one about the specific pathology that we're trying to track. And that generally gets us around to the most amount of attention we can, realistically expect from patients in a given sitting. As we move to, and that's regardless of whether it's on paper or whether it's digital in its various forms. So, but there are different ways of prioritizing that mixture of PROMs. Quality of life is one aspect, but it's not the be all and end all for every situation. But again, thank you for that question. So there's a couple that we had from other members here. So for the panel, what do you see as potentially the risks of not engaging in this sort of process in improving the learnings within an organisation? What are the key risks of not doing it as you see them? Gillian, do you want to kick us off?
Sure. Obviously preaching to the converted. What are the risks? Well, we have poor patient outcomes, we have unhappy patients, we have inefficient, unproductive hospitals that cost a lot of money. Then that flows onto a system level where we're not getting good buy-in to deliver the resourcing that we need to deliver the care that we need. If we're not getting good patient outcomes and delivering good services, there's population flow-on effects. I think, what isn't a risk? It's, if we're not engaging in these learning health systems, if we're not engaging in the ability to use clinically meaningful, patient-relevant information to drive innovation and conversation and improvement with all our stakeholders, with the patient at the centre, why are we here? If we can't do that, we're the system is not going to work. We're never going to get there.
And that's great, Gillian. And I would just add that if we're not doing it, then in the orthopaedic world, then someone else will, and that might be driven by industry or business or other interests. And I think it's really important that that's driven by the patients, doctors, and our system rather than externally.
Yeah, what What do you think, Kylie?
I don't know if I can add much more to that. I mean, I guess at a system level, we keep thinking, you hear that, it takes a long time to get evidence into practice. I think it used to be 17 years. I think more recent, which is 15 years. If we can speed up getting better care to people, it's using data to do that is how we're going to do it. So we need to engage.
Yeah, thanks so much, everyone. So the other question that we had was, Lorenzo, you tapped onto this in your talk around some of the challenges, but where do you see the optimal sort of champions and the enablers into getting started in this process? So, my experience working with the department was it started essentially with an idea. We didn't really have anything in place. Now that you're sort of a few years down the track, what have you seen as the key catalysts, the key drivers for that kind of process for those that are thinking about getting involved?
Yeah, I mean, I'm perhaps a little biased, but I think it's really important to have that engagement. And I don't know about the champions, but there needs to be clinician involvement locally and clinician desire to be involved with that. And that doesn't mean they need to start it, but we get to spend the time with the patients as the doctors, and it's that, I think if it starts at that doctor or clinician patient level, then it's a really good start. But in terms of then who needs to champion that, in our setting, we need people to be championing that at a more executive and higher administration level in order for us to make headway, because we can't do it alone, essentially. So I don't know if that answers your question, but that's the experience we've had.
Yeah, definitely. Yeah. What do you think, Gillian?
Yeah, 100% agree. I think it needs to be, the clinicians need to be engaged, the clinicians need to drive, but they need their executive to remove the barrier and, when necessary, invest for the outcome. And I think that's the benefit that we've seen in the GIRF program, is the information is really just a discussion starter. It's a point in time to have a chat, bringing the clinicians and the executives together so that the executives understand the clinical need, the patient need, and then they can remove the barriers to enable the clinicians to make the improvements, collect the data, do the registry, do the research. Their job is to get out of the way so that you can do your job. So we just need to bring them together as a driver and an enabler, and then, everyone should be able to progress.
Yeah, that definitely hit the main points for me. So I won't add too much more to that unless Kylie has got any comments.
No, summed it up very well.
Yep. No, I think we nailed it there. So I think Emma's giving me the hurry up over in the corner of the screen. So I'm going to thank the panel up front. Thanks very much for your time and your thoughts on this afternoon session. I thank everyone for attending, and I'll hand back over to you, Emma, to see us out the door. Thanks so much.
Thank you so much, Corey, and thank you to our panel. That was a fantastic discussion, very, very interesting. So that brings us to the end of our webinar, Driving Value and Innovation, Learning Health Systems in Practice, which was presented in partnership with EBM Analytics. Thank you to all of our panelists for joining us today. We would like to remind you before you go that applications are now open for the 2023 Value-Based Healthcare Awards, and there are 4 award categories that you can apply for: the Telstra Health Innovation Award, the Navigator Group Transformation Award, the Transport Accident Commission Equity Award, and a poster prize. The Centre also hosts regular webinars on topics related to value-based healthcare. So if you want to find out more about any of the events or activities, please see the AHHA website or subscribe to receive our monthly newsletter. Thank you again, everyone, for joining us today, and we look forward to seeing you again at one of our upcoming events. Thanks all.
Thanks, Emma.
Thanks, Emma. Thanks, Corey. Kylie.
Thanks for that.